Thanks, Dr. Gill.
Good evening, dear friends and colleagues. Tonight, our webinar will be about pediatric ophthalmology, and we have two eminent speakers. We have first Dr. Gurdeep, which is having a bachelor degree in medicine with honors from India. After finishing a 3-year on ophthalmology residency, he did a fellowship in pediatric ophthalmology and strabismus at the Aravind Eye Hospital, India. It's the largest eye care system in the world. After finishing his fellowship, Dr. Gurdeep joined Aravind Eye Hospital as a consultant in pediatric ophthalmology and strabismus, where he held a teaching post and gained advanced experience in pediatric ophthalmology and strabismus and adult laser cataract surgery and laser lacrimal surgery. Dr. Gurdeep has more than 30 international and several national publications in all peer-reviewed journals of ophthalmology. He has more than 22 years of ophthalmology experience and performed almost 10,000 surgical procedures. Dr. Gurdeep, the floor is yours.
Thank you, Dr. Daire. Thank you, dear, for all your support which you have given, especially the Dubai Pediatric Club and its eminent members. So it is my honor to present in your conference, which is going live in so many places in the world, which I understand. So thank you very much for everything. And I'll start the presentation. Why I chose this topic is because this
Doctor,
is.
can you share the screen?
Is it not getting shared?
No.
How? Where to go now? I go.
Click on share screen.
Share screen. Where is it? Screen. Is it okay? Now is it?
If Dr. Gurdeep is having problem, I can join.
You can minimize, doctor, and start the presentation. Go to the PowerPoint.
Yeah.
Yeah.
It is okay now?
Yeah, go to the presentation mode, doctor. Slideshow from beginning.
I can see. Is it okay?
Yes. Just click on the hide once, doctor. There is, you can see hide.
Yes, please. Thank you.
Click. Yeah,
Thank you.
go ahead.
Okay. Thank you. Thank you. Okay. So I'll start with my presentation. Why I chose this topic of universal eye examination of newborn. The aim of choosing this was because this is something which is going on in many centers in the world now, but unfortunately still we don't have that much of promptness in this part of the world, which I have seen. So that was one of the reasons why I chose this, because according to whatever studies we see or whatever studies which have been done, not in this part of the world, but in the other part of the world which is there, the incidence of anomalies detected by universal eye screening of newborn is quite high. It ranges from 2.4 to 34%. So that was the reason why I chose the topic of universal eye screening of newborn. And as we know that it is also a multi-speciality approach, and the aim is to reduce the incidence of childhood blindness. That was the reason of choosing this topic. So as I mentioned, early detection is the key to success in any kind of a medical problem. And here also the same holds true for universal eye screening of newborn. Early detection can lead to early treatment and early rehabilitation. So when we look at the screening of the eye in a newborn, there are three circles which we should always remember, which are easy to understand also, so that we don't miss anything as anomaly in any of these circles. And first is the outer circle, which we see, that is, this is what we call as the sclera. Anything related, any abnormality related to the sclera. Second is the limbal, like from the limbus, like what we see, the corneal limbal around the cornea, whatever we see, and this is the second circle. And third is just in the pupillary area. So it makes the things very easy for us to understand, and we try not to miss then anything which comes if we look in a systematic way what it is there. So as I told, the purpose is to avoid any long-term complications of any issues related with the newborn, which can lead to cognition or school performance problems later in life. And if one can save child's eye, it is uh, through this kind of a program we can do that, and it not only saves child eye, but it also improves the quality of life which the child is going to have in the coming years. And even identification of non-treatable eyes, we can do early rehabilitation, and that can promote the motor and the psychosocial development of a growing child, which is also need of the eye. So as we know very well from our good old MBBS days, that whatever happens in first 2 years of life has a greater impact in coming years to come. Suppose if you look at the brain, if it grows by 18 centimeter in head circumference during the lifetime, the 12 centimeter increase happens in first year of life, and 3 centimeter is in the second year of life. So this is the reason why the first 2 years of life are so important, and eyes are as such the window to the brain, and it helps in the development during the critical period. So what are the steps which we usually take in eye examination? As such, in any examination in any specialty, the history is the most important thing. And then for us it is the ocular history with the external eye examination. And usually what we do here is with all the uh, specialities relating to the pediatrics, we do see with the torch, and then we see with a direct ophthalmoscope. Recently, the screening has been done with some more advanced instruments in the form of like red cams, which can even help in the early detection of the posterior segment more than the anterior segment examination of the child. So what are the tools required as such when we go for the history, and we know that the history of any kind of a family disease which is causing a severe visual impairment, either it can be in the form of cataract or glaucoma or squint or nystagmus or retina related issues or any metabolic or genetic diseases. More related with the pediatric is the prenatal and the birth history, especially asphyxia, intrauterine infection, prematurity. Moreover, whatever it is, the other things which are related comparatively to each of them is like the hydrocephalus, infectious diseases history, and other anomalies like albinism, or Brown syndrome or chromosomal abnormalities in any kind of child who is having these kind of things and presented in the family also before. Examination starts with the external examination of the eye. And in the external examination of the eye, we look at the external structures ranging from the eyelids, eyelashes, globes, and then tear sacs and conjunctiva. And after that, the sclera, cornea, iris, pupil, lens. So this is how we look at, especially remembering the three circles, outer, middle, and the inner, so that the anomalies can be detected early. So these are the things what we usually try to do in the external examination, is look at anything like a infection or ocular malformation. Grossly what we look into, that is what we are going to talk in. And pupillary examination, we do see the light reflects and the pupil, and according to the pupillary examination also, many things can be detected very early in the life. This is how a normal eye looks in a newborn. You can see a very clear cornea with a central pupil, and iris pattern is looking, color pattern is looking fine. And you can see the sclera, it's how it looks, uh, quite normal looking sclera. You can see the conjunctival vessels a little bit over that. If you look at this eye, which looks quite normal, because with the healthy looking cornea, pupil is fine. You can see the sclera is also quite white. But if you compare this with this, you can very well see that there is some amount of difference between the outer circle, what we talk about the sclera here, and we can see the congestion here. So aim is to this detect the, if there is any abnormality or any problem in the eye. That is what the aim is. Treatment wise, it depends upon the type of the condition and what problem the child is presenting with, but detection is more important, then only it can be treated well. And pediatricians as such, our colleagues, they are doing good job with early detection of all these things, but it is just a brush up of what we see and how we have to approach for that. If you look at this is just an example. If you look at the pupil here, you do see some kind of a vascularity in this area. So this is something which is abnormal, which doesn't look normal. This is what we talk when we have seen the pupil in the previous slide, and pupil here, we do see there is some kind of a issue here which is going on. The reason can be any, which can be dealt later. Now, the most common form of presentation when a newborn is born is something like this. Now, when you look at this child, you see the puffy eyelids here. So now the question comes, is this normal? Is this abnormal? How to react and what to do? Now, the first thing which we ask is to the parent is, how was the delivery? Suppose if they have a prolonged labor or there was a face presentation, then there are chances that the child can have something like this, a puffy eyelid. But usually this kind of eyelid, it doesn't look any kind of infection in this. It looks more like because of the facial presentation, or when face is going through the birth canal, because of that, some pressure, this child must have developed some kind of a puffiness on the eyelids. So that can be the foremost first reason. The other reasons can be infection, but there are additional signs which we need to see in that. So then how to react to these kind of a situation, because the mother will ask the first question like that, why my child's eyes are puffy? So in those circumstances, we can just reassure them that this gets cleared in 3 to 4 days time mostly, and there is no discharge or inside. If you feel, if you're able to examine it is fine, then there's nothing to worry, and this will definitely go away in few days. Now this is the other very common thing which we see in a child, and this is also in the outer circle. If you look at this, This is a hemorrhage here, what we call as a subconjunctival hemorrhage. Now, this kind of a hemorrhage in a child, what should we do to this? Because the moment the mom sees the child's eye red like this, she gets frightened. So mostly we have to just wait and watch. The reason being same, as the child is going through the birth canal, there is so much of a pressure inside, and any blood vessel which is smaller one can burst and get something like this. Moreover, if there is any kind of a trauma in any way, forceps delivery or something like that, in addition to this small hemorrhage, there can be something here on the cornea also. But this looks like a very benign one, and this also we have to just wait and watch, and this will also go away with time. This is something alarming which we need to look at, and we can see that there's a lot of discharge coming out of eye. Why I put this slide is because there is also puffiness here. But this puffiness should not be mistaken as normal, because this is associated with this much discharge. And this much discharge of this color, definitely there is an infection which is there inside. And most probably it is the infection during the birth of the child, which has happened in the birth canal. That is the most common reason for this. The organism being different in nature, and the treatment modalities usually in these kind of things, if possible to open the eye, kindly do have a look at the cornea. Otherwise, this is what we call as a conjunctivitis, like neonatal conjunctivitis. This is what it looks like, and treatment depends upon what we get it here. But usually we start with something like Tobrex to start with, which is very safe, because Tobrex is safe in G6PD deficiency also, and we never know if the child is having any kind of a G6PD deficiency. So before we come to know anything about that, Tobrex is first to start, then we can follow the other medicines depending upon the culture as soon as possible. But if there is some kind of a corneal involvement, then the drops, the frequencies and everything is going to get changed. The second most common thing which you will see many times in a child is when the baby is born, and this baby is born with a swelling here. So when the mother looks at the child, and she's like very confused to see what is this here, and it has never been told to me. This can be seen even in the antenatal scans also, depending upon how much experience the person is, and whether he can or she can pick these things. And in utero, when they are doing the fetal scans, they can very well pick this in utero also. But suppose if it has been missed, then what does this means? It doesn't mean that there will be only in this place. It can be here also in the other side. It can be unilateral or bilateral, but here it can be absent at present, but later on you can see it after a few days. But this is what we call as a diacrysocele. In normally the literature says that in this kind of a situation where it, because the next will be, it will get into an abscess. So, and when it becomes an abscess, it will really be a problem in a child like this. So in those cases, they try to intervene with antibiotics, both topical and IV, and then they do the probing also. Is so early in this child of this, if there's an abscess, it needs to be drainage. But in my practical experience, I have seen almost 22 cases like this. And out of these 22, 21 cases have been resolved just with a simple sac massage, which has been taught to the mother. Only one case I had an issue. The reason being because the mother didn't do the sac massage at all, and that she landed into some kind of abscess here, and then leads to the orbital like cellulitis like picture, which needs a treatment later on. So this is what is the other thing which we usually see in a newborn. And these are the other common things which you will see, but not like this much extensive, or how the pictures are looking so alarming. The aim of showing these kind of, we know this is definitely, everyone knows that this is a hemangioma, and hemangioma has different kinds. It can be infantile, juvenile, strawberry, or whatever. Uh, in 5% of the newborns, you will get some kind of a hemangioma. But the aim of showing these kind of slides with hemangioma, there is only two things which are alarming. Is one is, like, if you see a hemangioma which is causing a lid to droop down completely, that is definitely alarming, because this is going to cause problem in the vision in the child later on. And the second one is, it has many associations which our pediatric colleagues need to rule out. Like, there are different kind of syndromes which are associated with that, which I'm not going into detail of. From that, that is like KM or microangiopathic hemolytic anemia or Maffucci or whatever the kind of a syndrome it is, that needs to be ruled out in situations like this. And when it is extensive like this, definitely, and a very simple blood test can help, like, to rule out whether there is any kind of a thrombocytopenia or platelet count. That will help, or bleeding disorders. That will itself, 90% of these associations with the bleeding disorders can be ruled out with just a simple blood test. So this is what I think my pediatric colleagues, they need to look at, and they will be definitely looking at these things. Apart from this, that it can be associated with very other kind of hemangiomas or vascular malformations, which can be there in any part of the body itself. And this is something different, which is portwine stain or something which we call. It has an association with what we call as the Sturge-Weber syndrome, which can have issues in the eye as well as the brain, and it can lead to epilepsy and glaucoma and all those things. So these kind of things, yes, definitely, especially these kind of things need a referral to a proper person. Now, coming to the lid, and I'm just talking about the things which need an urgent referral. Now, we can see this here. There's a defect in the lid here, which we call as a coloboma. It can be upper, it can be lower, it can be on both sides. Upper lid colobomas are usually medial, lower lid are usually lateral. So depending upon what kind of a coloboma it is, more to look at, more dangerous from our point of view is the upper lid coloboma, and especially if it is something like this kind of a coloboma. Why? Because this kind of a coloboma will lead to definitely corneal exposure and problems in long term. So these kind of colobomas, which are more than 2/3 of the lid, which we have seen, especially the upper ones, they need to be looked at as an emergency and need to be dealt very quickly. Lower lid colobomas, lateral 1/3, we can wait and watch till the child becomes a little bit bigger. But the management of this is usually surgical. That is first thing. For our pediatricians friends, the only thing which they can do that time is try to see that this should not have, the child should not have associated problem in the cornea because of the coloboma which is there because of the exposure. So if they can keep hydrating or lubricating, or if any other thing which they can help to keep the cornea moist, they should try to do that, or immediately if they can refer, that will be the best thing to do. Surgical management is the only management in these kind of thing. But associated anomalies, the other thing which our colleagues need to look at is the what you call as a charge syndrome, which can be with lid colobomas, with iris colobomas, with lenticular colobomas, with heart defects, with esophageal defects, with genitourinary defects. So those things we have to rule out, and that is usually what our pediatrician friends, they usually try to do. And these are the different kind of anomalies which you see. This is an ophthalmos that the eyeball has not developed at all. And this is the hemangioma which is already pressing. This can cause a problem because of the induced astigmatism, and second is the ptosis, which is almost going to be complete ptosis, leading to the virtual problem with the visual of this child in the future. This is what it is. The other kind of a lid issue is, like we see the ptosis here. This is a mild, you can say this is a severe ptosis. This is what we call a condition as a blepharophimosis syndrome. It has a association with other anomalies also, systemic anomalies also, which usually it's at autosomal dominant mode of a transmission in this, and the associated anomalies need to be looked with the pediatric colleagues, systemic ones, which has to be looked into that. And these are, like you can see, a small eye, but small eye doesn't mean it will be abnormal eye. Sometimes a small eye can have a full vision, even 6/6 vision. So, but if a small eye with other anomalies, then definitely there will be a associated, we say a complex microphthalmos can have something like a vision related issues more, and this is an ophthalmos. We cannot do anything in there, just socket reconstruction in these kind of babies. That is what it is done, and then artificial implants which will be put here to just give a cosmetic appearance, but from the vision point of view, nothing. And this can be associated with other anomalies of the ear or the face or the heart or the GI. That can be associated with these kind of things. And this is also, like we can see, a coloboma here. This is complex with cataract, with dermoid, and there is no eye has such here developed with lip anomalies. So this is something like a case of a golden hair syndrome. So this, as there can be no eyeball at all, which can be picked here because there is nothing here. And when we look with something like this, sometimes in the other kind of a condition where I showed you the lid coloboma, there can be associated retinochoroidal colobomas also there. So that we have to look into. And suppose if this involves the optic nerve and the macula, the visual prognosis is usually very poor. So this is other one that which leads to a painful blind eye, and this needs to be referred as soon as possible. It is with cyst, because this can lead to a painful blind eye, although there the visual potential in microphthalmos with cyst is nil. So just to prevent or just to keep the child away from developing pain and other things, so this eye needs to be dealt as soon as possible. This is something which is very, very interesting, and most of the people we see this. Many times we do see this, but the first thing after seeing this is the blue color is whether it is associated with osteogenesis imperfecta. But we do forget that there is something else also which we need to look at. Sometimes I had a child which was referred to me by the pediatrician, and with history of blue sclera like this. And when I look at the age of the child, it was just 4 months, and the pediatrician himself has ruled out the osteogenesis imperfecta, but he was not able to see there is anything related with that. Then I looked into that. Normally, things to remember is till 6 months, the sclera can be thin, and you can see this kind of a tinge in a normal one also. And if it is more than 6 months, if you rule out other things also, anemia, I think, is the other thing which needs to be looked at. And you can see here, this is the child who has blue sclera here, and after giving the treatment for the anemia, this child's sclera has turned out to be like this. So this is one thing which I have seen and I have learned also from this case. So I thought I'll put it. And these are not my pictures, but I have just learned in case like this because one was referred to me. So blue sclera can be seen in other ophthalmos eye also, and this is because of increased eye pressure, the scleral stretch and blue thing which you see, the uveal glow through that. So then there can be associated the dermoid like things which can go from sclera to the cornea. The reason for this is, again, it is having issue with, like, dermoid has all 3 layers which we know that very well, and it is also a congenital anomaly with associated anomalies which need to be looked, and this can also lead to a problem in the vision as such because of the induced astigmatism. But if it is coming to the pupillary area, it can further affect the vision, and associated anomalies which we need to see, we have to rule out according to what we are seeing. So this is like you can see limbal dermoid with lid coloboma with pre-auricular tag, and this is what the baby's autopsy, when before autopsy the baby. You can see the pre-auricular tag here also in this baby. This is something which we see, then that is also an emergency, which we, when we see that the cornea is this in middle circle starts becoming into a trouble, that is cornea, and you see the cornea is becoming totally becoming white like this, and this is just maybe 2 to 3 days after the birth. Definitely you have to, without delay, you have to send this patient child as soon as possible. The reason being the congenital glaucoma, the only management is surgical, and earlier the better. This is what it is taught, and this has an association with congenital heart disease. So for our pediatrician colleagues, because as I told you, the only treatment is the uh, surgical treatment. So we have to rule out these things before we land up into something like the surgical management of a thing. There is one other thing which we call congenital hereditary endothelial dystrophy. Looks like a congenital glaucoma like picture, the child, but it develops, it can be very faint, but it becomes more over a period of time, may or may not be associated with nystagmus depending upon the type which it is. And this is one thing which is also kept in mind. But in early, like 2 to 3 days of life, a cornea like this which I showed you, definitely we have to look at the congenital glaucoma which we need to look at. So this is other type of a cornea. The size, when it becomes less than 10 millimeters, we call it as a microcornea. And microcornea also we can see here very well. Why it is important from a pediatrician point of view? Because it has an associations with myotonic dystrophy, fetal alcohol syndrome, achondroplasia, and EDS. So these are things when we look into something like that. So the pediatrician colleagues will have to look about something like this. So mostly it is an autosomal dominant type of a character, and can be associated with congenital cataracts and other uh, problems associated. This is where the size of the cornea is quite big. You can see here in a newborn like that. So this is what we call as a megalocornea, usually X-linked problem, and more in males more. Some people say that it has an it is described sometimes as a arrested ophthalmos phase as such. So importance from the pediatrics is can be associated with craniosynostosis, frontal bossing, hypertelorism, facial anomalies, dwarfism, and sometimes all these kind of a syndrome like Down or Dalport, they can be associated with these things. So this is now the coming to the iris related issues. Then iris can have a different type of anomalies which can be detected at the birth, which can be vision threatening also, as we are seeing this one here. We can see this one here, because when it will obstruct the pupillary area, definitely the problem will be more. So this is what we call as a Peters anomaly, and it has 3 types. Depending upon what type it is there, the vision can have a problem and needs an urgent referral because of the vision related issues which will be there. So you can see if the child is having something like this, so it definitely needs an urgent referral, because otherwise child will definitely go into amblyopia. And for the pediatric colleagues, the associations are ASD, AVSD, and PDA. And genitourinary, with there can be developmental delays, ear defects, skeletal and spinal facial defects. And then there are different other different types of syndromes which can be because of the problems in the iris, which is axon field rigor, which has also associated. Rigor has an association with many other anomalies also. It's a autosomal dominant, bilateral, symmetrical, and usually glaucoma is seen in 50% of these cases. Why I am mentioning about this one here? Because later on the child can have these kind of issues, or skeletal issues, or facial issues. So these are the things which pediatric colleagues can have later when they see some child with a polychoria or some different kind of a pupil shape. They can definitely look into that, whether it is going to attach itself to the cornea, the iris is attaching, or is it away from the cornea, and depending upon that, many things can be detected early. this is something which is very, very important. And sometimes you do see something like this. You can see the heterochromia iridis. So what does it mean is like you see the colors here, they are different in this child. And you see the colors, they are different in this child. Sometimes we do see a sectoral atrophy of the iris that can be normal, which is sometimes people refer even to me, I have seen as a coloboma, but that is only just a sectoral atrophy of the iris. And heterochromia iridis, why I mentioned here, because it has a very known association with something like this Wardenberg syndrome, but this needs to be looked at along with vitiligo, poliosis, and telecanthus. So this can give some kind of a clue. Maybe this can be Wardenberg. So this is what it is. So that is why I mentioned here. Regarding the pupil, pupil can be of different sizes like this. There will be a normal, and this is a small size, which is we call it anisocoria because of the pupillary abnormality which we are looking at here. And anisocoria as such needs to rule out few things. And in children, if possible, it is very, very difficult. I can understand that it is not easy, but if possible, Horner's can be thought of. If it is possible, congenital Horner's it can be. And when the pupil is totally absent or majority of it is not there, which we call as aniridia. And why I mentioned about aniridia here, you can see almost all the pupil is not there, only just a remnant like, because it has a very known association with that, which is Wilms tumor. And if something like this, can we do MR and rule out Wilms tumor? We can, depending upon what we are thinking, because isolated aniridia without systemic involvement is very well known. And only thing is when there is a PAX6 gene, then we do need to rule VAGR and Gillespie, both we need to rule out, because that is where we look at these kind of chromosomal deletions of 11p13, and that can be uh, associated with the aniridia. And this is something different, and like you can see a pupil like this sometimes, so which can be polychoria. And usually I just talked about rigors, where we have other skeletal, cranial, facial, and dental problems. So coloboma you do see many times in your pediatric cases also. And coloboma can be like this iris coloboma. It can be associated with lenticular, it can be associated with retinochoroidal, it can be unilateral or it can be bilateral. So that is what prognosis from the vision point of view is still good if it doesn't involve the nerve or the macula. So there are different associations with these kind of colobomas, like Charge syndrome, which we know, and which we have to really look at, like coloboma and heart disease and atresia cona, retarded growth, genitourinary problems, and ear abnormalities. So this is when we look at something like this, the charge should always be charging us to look for what is going on, which can be there in the child. If detected early, can help the child also. And this is what we are always worried, and what we always talk about is leukocoria, white reflex, which you see. Only thing is, when you are looking at the child, you just make it sure that you have switched off the light, and do look in different directions, not only in the straight one, but look in different directions. If you are not able to see something like this in the straight, look in different directions, maybe you will be able to see something. But still, if there is some kind of a doubt in this kind of a situation, you should never ever wait. Immediate referral should be done, because all these are blinding conditions, which you can see here: cataract detachment, ROP stage 5, and retinal vascular abnormality, intraocular tumor. All those, these we very everyone knows about leukocoria and its causes. why I just mentioned is because of the urgent referral. And if somebody, even last month I had a case where it was missed and child has come at 6 months of age. So that is something which we need to really look into, so that, because this is really a blinding condition, and which can be dealt properly, can have a good results.
Dr.
Dr.
Gurdeep, we have
Gurdeep,
more
sorry, I'm
5 minutes.
Thank you.
just
So this is
2-3 minutes left.
Thank you. Okay. So this is, if take-home message is something like this, in which cases we do need urgent referrals, is cases something like which where you see the purulent discharge like this, or hazy cornea like this, or lid, where lid defects you are seeing something like this, or again hazy cornea, and where you see a corneal opacity which is occlude or obscuring the, like the light reflects, and this is something again like a white reflex and acrocystocele, which can become a lacrimal abscess and cause more problems, or something like this. The syndromal associations of all these have to be ruled out. That is what we need to look at. Thank you very much for your kind attention.
Thank you very much. Thank you very much, Dr. Gurdeep, for being on time and for this nice, excellent lecture on problems of the eye in pediatric age group. Now I will invite Dr. Zorab to welcome. Dr. Zorab, you are late a little bit,
Thank you very much. Thank you, Dr. Gurdeep, for excellent presentation. Thank you, Dr.
Thank you.
Diaki. I apologize. I was a bit late because of the emergencies. Now, I would like to welcome all viewers. I will share my screen. And it is okay, then please let me know.
Can you go to the presentation mode, doctor?
With F5. F5 it is not bringing it. I just. If it is not there, I will just explain on this slides. Now, is okay?
no, it's not coming, Dr. Zorab. Only the introduction is there, the way pediatric lab.
No. I mean, is it okay?
Not in the presentation mode, as the slides only we can see. You can go ahead.
Let me go. Let me go ahead.
Go ahead. Go ahead, doctor.
Good evening, ladies and gentlemen. Welcome to this webinar. Sorry, we are. My part is a bit late. As you know, this our speaker, Dr. Gurdeep, consultant pediatric ophthalmologist from Al-Zahra Hospital, and Dr. Alan Mulvey from consultant pediatric ophthalmologist from Al Jalila Children's Hospital. There are speaker tonight. Our moderators are Dr. Diari Muhammad, consultant pediatric surgeon from Al Jalila Hospital, Dubai, and Dr. Kalpana Sen Gupta, head of Department of Pediatric and Secretary of the club. Dr. Kalpana is not feeling well. She's there. Dr. Diari is taking over. Well, now this is a question for the viewers. Who is this gentleman? You have to tell us. Those who answer right.
It's not coming, doctor. You're still in the first slide.
Pardon?
You're in the first slide still.
This is the first. It is not coming.
No, doctor.
Not coming, Doctor.
Wait. Let me just. I think. Is it okay? Tawfiq?
Yes.
Is it okay? Can I go ahead?
Just go to the next slide, let's see.
Unfortunately, we're having same problem. I think that, Tawfiq, I think there is a problem. Let Dr. Alan to start. I think I have to go and delete the slide and then start sharing. So you start with Dr. Alan, then I'll present later. Sorry. I think I have to delete and then, wait, once again, I'll just try to see. I think, let Dr. Allen present, then I'll present at the end. Okay, please.
Okay. Thank you, Dr.
Dr.
Zohrab.
Diari, yeah.
Thank you, Dr. Zohrab. Now our next speaker is he is Dr. Alan. He's a consultant pediatric ophthalmologist at Al Jalil Children's Hospital, Dubai. He is he was fellowship trained in pediatric ophthalmology and adult strabismus. Before joining Al Jalil Children's Hospital, Dr. Alan was practicing as a consultant ophthalmologist in Edinburgh, UK, since November 2002. He was based at the Prince Alexandra Eye Pavilion and the Royal Hospital for Children and Young People, Edinburgh, UK. Dr. Allen, particular areas of interest are complex pediatric and adult sequence surgery, retinopathy of prematurity, neuro-ophthalmology, and pediatric accidental and non-accidental injuries. Dr. Allen, are you with us still?
Yes, I definitely am.
Yeah, please. The floor is yours.
Right. We had some difficulty sharing screen earlier, so we'll see if this works.
We will see, yeah. So Mr. Tawfiq will help you.
Okay. Can you see my screen?
Yes.
Yes,
Right.
sir.
Okay, good. So I'm going to talk about the sort of symptoms that you might expect or be worried about in a child that may or may not have a brain tumor. So this is a kind of common concern for pediatricians and emergency room doctors and pediatric ophthalmologists and oncologists. So I was asked to present to give a few sort of suggestions or learning objectives. I think it's good to have a sort of an idea of what we want to get out of a talk. So learning objectives are pretty straightforward here. One is to try and have an improved understanding of which aspects of the history should raise concern about serious intracranial pathology, such as a brain tumor. And the second is to try and improve your understanding of which aspects of the examination should raise concern about serious intracranial pathology. So history and examination. In the UK, about 10 years ago now, there was a case that was in the media a great deal. An optometrist, so that's a high street optician, as opposed to an ophthalmologist, was convicted of manslaughter when they missed papilledema in a child. And this got a lot of attention, especially in optometrists. In the UK, optometrists can examine patients and deal with certain problems, and they refer a lot to ophthalmologists, but they deal with a lot themselves. The irony here is that almost certainly what happened is this child was seen in a big chain optician, where, you know, a big place where there's multiple opticians and technicians, and they probably looked at the wrong pictures. They looked at the picture from the wrong child, because this child was brought along with multiple siblings present. So I haven't seen the original images, but apparently, if they're to be seen, this child very obviously had abnormal optic discs and papilledema. But it caused a lot of difficulty in the UK and a huge upsurge in referrals to pediatric ophthalmologists from doctors and optometrists concerned about papilledema. There's a lot of reasons why the nerve at the back of the eye can look abnormal. There's a classic textbook appearance that you can see in the top right picture here, but there are many reasons why it can look abnormal. There's no one particular test or group of tests that gives you a conclusive answer as to whether an odd-looking optic nerve is due to raised intracranial pressure or some other more benign cause. But my general advice overall is remember that you are a doctor, you have an MD, you're used to taking a history and examining a child. And don't forget the basics of medicine, of history and examination. So when someone has papilledema, and papilledema is a very specific diagnosis. It means a swollen optic nerve due to raised intracranial pressure. The veins at the back of the eyes, and hopefully you can see my arrow there, they're a bit more dilated than normal. The margins or the edges of the optic nerve are indistinct and blurred. The small vessels on the surface of the optic nerve are often obscured. The disc is hyperemic or a bit redder than normal. There may be hemorrhages in or close to the optic disc, like these ones I'm pointing out with the arrow here. There can be cotton wool spots, which are little sort of like literally white fluffy patches. And there can be folds in the retina. You can just about see a fold here in the left eye in the retina. These folds will be circumferential to the optic nerve. It's because the nerve is elevated and literally pushed into the eye because of the swollen optic nerve sheath behind the eye. And that's because the subarachnoid space around the brain extends with the optic nerve right up to the back of the eye. So here's a case of a child who was seen in October of 2019, 11-year-old boy. His parents brought him to see their family optometrist in a high street. He'd had a 5-day history of headaches and vomiting, and the optician thought, or the optometrist thought, he had papilledema. The child was otherwise well. He had no history of ataxia or falling over. He had no tinnitus, he had no head tilt or other neurological symptoms. So as often happens in this situation, the parents are so anxious they can't wait to see an optometrist or a pediatric ophthalmologist within a day or two. They often turn up to the nearest pediatric emergency department. So the child was seen in the emergency department in Edinburgh one evening, and looking at the record, that was recorded that he had normal gait, he could walk fine. His pupils were equal and reactive. He had normal eye movements. He had no nystagmus. His cranial nerves were intact. He had normal tone, power, sensation, coordination of the upper and lower limbs. And basically, he had a normal neurological examination. When a child presents in this sort of situation, it's often very difficult to not intervene further. Hopefully, you can see there was an emergency CT scan done. Just like, certainly in Al Jalila, it was the same situation in Edinburgh. Out of hours, you could get an urgent CT scan, but not an MRI scan. And while it's not the perfect examination when you're trying to outrule intracranial pathology, it is helpful in that it often sort of puts people's minds at rest to a great degree. But basically, this lad, this 11-year-old boy, he had an urgent CT scan, which was basically normal. Now, in Scotland, the optometrists, when they referred patients to the local ophthalmology department, they do an electronic referral, and they can attach photographs of the optic nerves and visual field tests and other information, which I'll come to in a moment. Anyway, this child had presented to the emergency department, everybody very worried, and we were asked to see this child in the pediatric eye clinic the following day. And just summarizing the main points of the examination, the child didn't report any double vision. He had no sixth nerve palsy. I also felt that his cranial nerves were normal. I did a visual field test, just confrontation, bringing a target in from outside the field of vision to inside. So this wasn't an automated visual fields test. When I examined the optic discs or the optic nerves, I felt they were a bit elevated and irregular, but they had no hemorrhages or cotton wool spots, and the blood vessels were not dilated. So the optometrist had attached pictures of the optic nerve taken with a thing called an Optos camera, which is a camera that a lot of opticians have in some eye departments, and it can take very good pictures of the back of the eye without dilating eye drops. So it's very, very helpful. So if you put enlarged pictures here, it's slightly different to the normal type of pictures you might see of optic nerves. But basically, this child has slightly anomalous or odd-looking optic nerves. The blood vessels are about normal caliber. Sorry, these black lines you see here are the eyelashes. This particular camera tends to show up the eyelashes. So in case you're wondering what they are, they're not some horrible disease, they're just normal eyelashes. So his optic nerves were basically a bit small and irregular and a bit odd looking, but overall basically normal, certainly to an ophthalmologist. Now, apart from history and examination, we have a lot of technologies that we use to help evaluate the optic nerve. And one that's used a great deal now is a thing called OCT, or optical coherence tomography. It's basically an infrared light version of ultrasound. It's infrared light waves bouncing off one another, but it's an altogether higher level of resolution. So we can literally, and hopefully you can see my cursor moving there, can measure the different layers of cells in the retina at the back of the eye. And it has different modalities. One of them measures the thickness of the retinal nerve fiber layer around the optic nerve. And this green line here is, well, this is as if it is sort of flattened out to give a flat picture. And it shows various layers. And there's a few little bumps here that shouldn't be there. And when the thickness of the nerve layer is compared to sort of an age match normal, in parts it's normal thickness. That's this. The black line here represents the thickness of this child's nerve fiber layer, leaving the back of the eye to form the optic nerve. In parts, it's normal thickness, and in parts, it's quite abnormally thick. And it's because he had little collections of calcium material in the optic nerve called optic nerve drusen, which are quite a common finding in optic nerves in children and in adults, but they can give an anomalous picture of the optic nerve that resembles papilledema. So we sometimes do a thing called autofluorescence in this situation, and while it wasn't very obvious, there was one little bit of one of the drusen in one eye that shone with blue light, which helps confirm that it was optic nerve drusen. The point of this case is that sometimes the symptoms can be a little bit misleading, but in a child who's otherwise neurologically well, if there's just headache, it's likely that the child does not have some serious intracranial pathology like a brain tumor. Another common condition that can cause an odd-looking optic nerve is when the nerve comes into the back of the eye at an angle. Instead of coming straight in, perpendicular to the back of the eye, it comes in at a slight angle, what we call a tilted optic nerve, so that the temporal part of the optic nerve near the macula is reasonably well defined. The nasal side is elevated and a bit indistinct. And it's very common. It's usually in kids who are myopic or short-sighted. So the thing about papilledema, or swollen optic nerve, it's not just a swollen nerve, it's a swollen nerve secondary to raised intracranial pressure. And there are a lot of causes, but the main ones we worry about, the main causes of papilledema would be intracranial tumor, idiopathic intracranial hypertension, and also severe just systemic hypertension. What are the sort of associated clinical features you would get with papilledema? Well, one is headache. We think about, or with raising intracranial pressure, headache, you might get nausea and vomiting, particularly in the mornings, blurred vision. People with raised intracranial pressure often report what are called visual obscurations. Their vision goes dark in both eyes for 10, 15, 20 seconds and then comes back. So it's a very sort of distinctive description when patients describe it. When you have raised intracranial pressure, you may well have a sixth nerve palsy, because when you've got raised intracranial pressure, the brain is usually pushed down somewhat and the sixth nerve gets stretched over the petrous, over the sphenoid ridge and petrous temporal. So you can get a sixth nerve palsy. You can get ataxia or unsteadiness, tinnitus, which may be pulsatile, and sometimes a head tilt. So when there's a brain tumor and raised intracranial pressure, you can get some or all of these features. It's very rare to have papilledema and none of the above. So when there's just a funny looking optic nerve, and maybe headache, there's usually other signs or other symptoms as well, symptoms and signs. The particular situations when you should consider that a headache might be associated with a brain tumor is any child with a new persistent headache. Persistent probably means 4 weeks or more. Headache in isolation without nothing else is unlikely to be a brain tumor. Brain tumor headaches can occur at any time of the day, though they're often more prominent on waking from sleep, as you know, because when you're sleeping, you develop a relative degree of hypercapnia. The cerebral venous sinuses tend to expand a little bit, so the pressure is a bit worse. Younger children may not be able to describe that they have a headache. They may or may not, but they may just have a difference in their observed behavior. So headaches that might require neuroimaging are ones where if there's a persistent headache that wakes a child from sleep, persistent headache that occurs on waking, persistent headache in a child under 4, confusion or disorientation with headache, and persistent headache with one or other symptoms such as double vision, ataxia, tinnitus. Also, some children can have chronic headaches, but if the character or the pattern of the headache changes, so if their normal migraine headache has become something new or different. So don't dismiss it just because a child has a long history of headaches. If the pattern changes, that can occasionally be due to intracranial pathology. And then the other things you might worry about apart from headache, well, I've mentioned nausea and vomiting, the various visual signs such as reduced vision or constricted visual fields, abnormal eye movements, abnormal looking optic nerve, generalized motor symptoms such as normal gait and coordination, focal motor weakness, and then endocrine ones, which you tend not to think about as much, but and are a little bit more subtle. Failure of growth, delayed or arrested precocious puberty, galactorrhea, primary or secondary amenorrhea, increased head circumference, behavioral change, diabetes insipidus. All these things are potentially associated with raised intracranial pressure. And also, if a child has 2 or more symptoms, such as vision symptoms and headache, ataxia and headache, 2 or more is definitely an indication to carry out urgent neuroimaging. So when we're assessing a child with a possible brain tumor or headache or suspicious looking optic nerve, I always consider careful structured history to be absolutely crucial. And then the examination, a basic ophthalmic examination, including vision, eye movements, and a good examination of the optic discs. And taking good quality pictures of the optic discs is also very helpful. What's of slightly less value is visual field testing. It can be helpful, but it can also be misleading, especially automated or computerized visual fields. They tend to give a lot of false positive field defects in kids. I mentioned a technology called optical coherence tomography, or OCT, and we find this very helpful, but it's very helpful for monitoring a suspicious optic nerve where we're not sure. It's less obvious in or less helpful perhaps in diagnosis, unless it's a very obvious barn door type papilledema. And previous photographs of the optic nerves are sometimes misleading because photographs are sometimes taken with different cameras at different angles and different lighting conditions. So when we see a child with an odd-looking optic nerve and we've taken a history and done an examination, we do our OCT scan of the optic nerve. And here in this particular child, the green, yellow, and red are the sort of the normal range for age-matched patients. The black line is the patient's retinal nerve fiber layer. And in this child, their nerve fiber layer is kind of more or less normal thickness. If a child has some sort of pathology or raised intracranial pressure and the nerve is very swollen, this black line will be very raised outside of the green area. And it can be can be useful for helping to, or be useful for monitoring changes in the papilledema by doing sequential scans to look at the thickness of the nerve fiber layer. You can tell basically whether papilledema is resolving. So, sorry, this is labeled case 1. It's actually case number 2. So this is slightly different case. A 16-year-old female presented again to the optician, and that's very common in the UK that people often present first to an optician, presented with headaches, intermittent visual disturbances, and worsening of a pre-existing squint that had been there since early in childhood. The father in particular reported that the squint had been worsening significantly over the previous 5 days. Taking sort of a more detailed history from this young lady, she said she'd had a 2-month history of headaches. They were frontal, they were every 3 to 4 hours, but only occurred during the day, never on waking, and they didn't wake her from sleep. She'd also had a 1-month history of intermittent visual obscurations, where basically vision in both eyes went a bit dark, like a sort of tunnel vision effect, especially when she stood up. She also reported new onset tinnitus, but had no other neurological symptoms. So I showed you this chart before and about when you might consider neuroimaging in a child or adult for that matter, but someone with a persistent headache and 1 or more symptoms. So this girl had persistent headache for 2 months. She did have 1 or more symptoms. She had an increase in her squint. She had visual obscurations or visual symptomatic changes in her vision, and she had tinnitus. So she'd had squint surgery at age 18 months, but had no ophthalmology input for many years. On examination, her vision was slightly reduced in the left eye, which is the one that had the squint, and that was kind of expected given the history of squint. Her pupils were reactive. Her visual fields were normal on confrontation visual field testing. I don't tend to do computerized visual fields in this situation. Her eye movements were normal. She didn't have a 6th nerve palsy, so she didn't have a neurological type squint, just an increase in her existing squint. So pictures of the back of the eye. This is with the same kind of camera that we showed that I showed with the previous child. Here are the eyelashes, but here the optic nerve looks very obviously abnormal. You really can't make out the margins of the optic nerve. It's very indistinct. You can't, the blood vessels as they pass over the surface of the nerve are obscured. You can maybe get the impression that with this blood vessel here that it's having to lift or arch upwards to get into the nerve. There's a flame-shaped hemorrhage. And the other eye, I'll come back to that lesion in a second. Again, very kind of abnormal looking optic nerve, which is swollen with dilated blood vessels and hemorrhages, and probably a cotton wool spot there. This thing here is a congenital spot in the eye. It could either be a harmless congenital anomaly or possibly a small toxoplasmosis scar, because we see those quite commonly in the eyes, but it's unconnected with the current presentation. So to summarize, this young lady had persistent headaches, new or worsening of an existing squint, and swollen optic discs. So not surprisingly, she had a scan. On the left is the T2, and on the right is the T1 weighted image. And this young lady had a left thalamic lesion, likely low grade, but it was causing obstructive hydrocephalus. And she had an endoscopic third ventriculostomy, which is often done in this situation by the neurosurgeons to relieve the intracranial pressure, to relieve the immediate symptoms and allow planning for more definitive surgery and chemotherapy. So once again, headaches in a child are always a concern, but all children have headaches at some point, especially if they don't drink enough water. And something I've noticed since I moved to Dubai is I need to drink a lot more water. If the air, it's a very dry environment. If you don't drink enough water, you feel rotten and you have a headache. So in the history, you want to ask, is the child drinking enough water? I'm sure it's a question you're used to asking. Is the headache in isolation, or are there associated features? Are there double vision new onset squint, ataxia, tinnitus, head tilt, all that sort of thing. If it's waking the child from sleep, if it's occurring on waking, if it's there for maybe a month or more, and if there's other associated neurological features, then the child needs an urgent MRI scan. So I hope you found those cases helpful. Not every child with a headache has a brain tumor, but probably every child with a brain tumor has a headache. But they usually have other features as well, ataxia, and new onset squint, tinnitus, other things. I've seen lots of kids with brain tumors over the years, and the history is usually relatively short. It's sort of somewhere between 1 and 2 months. A kid who's had, symptoms for longer than that, it's usually not something like a brain tumor. If the symptoms are very acute, again, it's usually not a brain tumor. So a well child who develops an acute squint and no other features, rarely, if ever, in my experience, has a brain tumor. It's the one where it comes on over weeks or a month, 6 weeks, that sort of period of time. They're the ones you need to worry about. So that's my talk finished. I hope you found it helpful. I hope it was educational to some degree. I'd be very happy to take any questions.
Thank you very much. Thank you very much, Dr. Alan. Thank you. It was really a nice presentation and very useful. Thank you very much. Dr. Zohar.
Good.
Thank you very much, Dr. Alan. Thank you for excellent presentation. I'll try to share my screen this time. Hopefully it will come. I think the Tawfiq, if you share my slide, it will be better.
Yeah, try one. Shall I share?
Pardon? Yes. If you share, I will talk on the slides, so we will save some time. Once again, good evening, ladies and gentlemen. Our annual conference is on 9th. The 9th annual conference is on Saturday and Sunday, 29th and 30th April at Conrad Hotel. All are requested to join us. Next, please. Well, our webinar is CME accredited in collaboration with NMC Specialty Hospital, Dubai, and sponsored by Vita Biotics UAE. I would like to thank the country business manager of this company, Mr. Tawfiq Ali. Next, please. This is our question. Those who answer question, they will get a good prize from Mr. Tawfiq. Next, please. Well, beautiful Dubai. All are welcome. Those who have not seen members of Dubai Pediatric Club in the beginning, and the member, these are the recent. Next, please. You will see the members of Dubai Pediatric Club, members of the, I would like to just say, members of the organizing executive committee, myself, Dr. Joshi, Dr. Kalpana, Dr. Diari, Dr. Amir, Dr. Ayman, Dr. Rafia, Dr. Bandari, Dr. Leila, and Dr. Khaled. Next, please. Well, as you know, our speaker today, Dr. Urdib and Dr. Alan, I mentioned about that they are consultant pediatric ophthalmologists at Zahra and at Jalila Children's Hospital. Next, please. Next, Tawfiq. Tawfiq. Yeah, these are I have mentioned. Now about the 9th, next please. 9th annual Dubai Pediatric Club conference at Conrad. Please join 2 days, 1 day webinar, 1 day physical, and gala, of course, gala dinner. Next, please. Well, always Mr. Tawfiq with us. He's sponsoring since 2015. We would like to thank him. Now, I would like to give a very brief account of history of ophthalmology and pediatric ophthalmology. Next, please, in few minutes. Well, always I start in the memory of Hippocrates, the father of medicine. Everything starts with him. Next, please. Well, as Hippocrates says, first do no harm. This is a principle in all fields of medicine and pediatrics. Next, please. Well, the word ophthalmology, it comes from the Greek root of the word ophthalmology. Ophthalmos means eye, and logia means the study of this code. That is the study of the eye. Next, please. Well, I would like to mention here from Okitensky this quotation. Those about to study medicine and the younger physician should light their torches at the fires of the ancients. So we have to remember the ancient. Next, please. Well, this is a very good picture from American Academy of Ophthalmology. Sim has written. See, it starts from 2250 from ancient Babylon. Then comes to ancient Egypt. Then ancient India. Then it goes to Greek. We always mention Hippocrates, but in the ophthalmology, it is 2250. Then comes to the era of the ancient Rome. Then Arabian era, Renaissance, and Golden era, and from about 67 onwards, the newer development. Next, please. I'm not going to the detail of that. Well, all Indians should be proud about the history of ophthalmology in India. Shushruta, the most celebrated physician and surgeon in India, is widely regarded as father of Indian ophthalmology. Here you see, Shushruta is performing cataract extraction. See, long back. Next, please. Well, those who are in ophthalmology, they must have come across Sir Luke Elder. Those who have been to old libraries, I found 40 volumes of his books. Now, maybe more. From the eye of insect to human being. So remember him. A. Scott was dominant force in British and international ophthalmology for more than a quarter of a century. We must remember them. Next, please. Well, George Batish, a German physician who wrote extensively on eye diseases in the 16th century, was perhaps the most well-known oculist of his time and is considered by many as father of modern ophthalmology. Next, please. Well, about the eye test, sometimes this happens after doing a lot of tests. Next, please. Yes, about the history of optometry. Erwin Borish, the father of modern optometry. His work influenced almost every aspect of optometry throughout his long life. Next, please. I'm going fast to save some time. Well, in 1753, Samuel Sharp performed the first documented intracapsular cataract extraction. It is interesting to know that Dr. Samuel used his thumb to expel the cataract from the eye. Very interesting. Next, please. Well, in 1949, Sir Harold Ridley, a British ophthalmologist, implanted the first intraocular lens. Next, we must remember them. And the word about the establishment surgery. The word establishment is derived from the verb establishment, meaning the term. The first documented establishment surgery was performed by John Friedrich Dieffenbach, a German, on October 26, 1839. He corrected esotropia of the 7-year-old child by medial rectus myotomy. Next, please. Well, about the ophthalmoscope, we are talking a lot. The ophthalmoscope generally is considered to have been invented in 1851 by German physiologist Hermann Helmholtz. Next, please. This is his ophthalmoscope. Well, about our question, Dr. Marshall Parks is considered as father of pediatric ophthalmology. Those who have answered right, Mr. Tawfiq will give them a prize. Next, please. Well, Dr. Frank Pottenbader, was an American physician frequently credited as the world's first pediatric ophthalmologist. Now, Dr. Marshall Park, the student of Dr. Kostenberger, known by many as the father of pediatric ophthalmology, began the first ophthalmology fellowship training program at Children's Hospital of Washington. Park was instrumental in establishment of the American Association of Pediatric Ophthalmology and Strabismus. We must know him. Next, please. Well, and now there is a question in the mind of all people. This is a poster in 1973, but written that John is not really dull, but he may need an ophthalmologist. The American Academy of Optometric Association has given this guideline. According to them, infants should have the first comprehensive eye exam with an optometrist at 6 months of age. It is generally recommended an examination from birth to 2 years old. If there is a suspicion of a problem or a family history of a problem, children then should receive additional eye exam at 3 years of age and just before they enter the kindergarten or the first year. But in the Nelson, I was reading, it is written, the proper eye examination in children should be done at 3 years, 3 to 6 years every year, and after 6 years every 2 years. Next, please. Next, well, about our speaker, everybody knows Dr. Alan. Dr. Alan is a consultant pediatric ophthalmologist at Al Jalila Children's Hospital. He was for a long time in England, UK, and he has done a lot of work there, and recently he joined Al Jalila Children's Hospital. Well, I have circulated all the profiles. Next, please. And Dr. Gurdeep Singh, a consultant pediatric ophthalmologist, he did his training in India at Arvind Hall Hospital, the biggest chain of the hospitals in the world. And then he joined Al Jalila Children's Hospital. Next, please. I'm going fast to have time for discussion. Well, these are references. Next, please. Beautiful Dubai. Once again, I invite all of you next. Thank you very much. Thank you very much. Now I would like to request Dr. Diari to start moderating the session question and answer. Dr. Kalpana is there, but unfortunately he's having a bad laryngitis, so today she will watch us. Dr. Diari, over to you. Thank you very much. Thank you, Sophie.
Thank you, both speakers. Thank you very much. It was really a nice scientific session tonight. We have some questions, and most of them has been answered. But Dr. Gurdeep is there. Can we have his Dr. Gurdeep?
Yeah, he joined. His
Yeah.
mic is.
Yeah, it might be off. Dr. Gurdeep, I know that you answered a lot of questions on the question and answer session, but there is a question which they are asking about the ret reflex. What's the importance, and for the audience to know, not only for the one who asked, please. Can you elaborate on that part?
Red reflex is basically the reflex which gets originated from the retina. What happens is when you throw a light from a direct ophthalmoscope which passes through the pupil and goes to the retina, the reflex which is generated from there, it is getting transmitted back, which you see as a red one, and that is what we call as a red reflex. Now, looking at the red reflex, what basically we should try to do is like the room should be not lighted. It should be maybe semi-dark, or if possible dark, it is better. And the second thing is, when you are detecting the red reflex, the distance also matters. Maybe roughly an arm's length is fine. Sometimes on the direct ophthalmoscope, we just keep +2 or sometimes +3, even sometimes +4, but we start with +2 and then start looking at throw the light at the pupil and look at that, what is going on. Now, The problem arises when there's a discharge which is covering the pupil sometimes in a child, or the pupil is very small. Then also it is very difficult to look at that, especially in premature babies. It becomes sometimes very difficult to look into that. So in those cases, maybe it can be dilated to see the red reflex. It doesn't takes much time, and it helps in many of the ways which is there, and it is very, very helpful as such.
Thank you. Thank you. So there is another question from Dr. Ghassan. How can we diagnose vision problem in neonates?
Clinically, the only thing which we see in neonate is the light reflex.
Only right.
That is what I do. Clinically, I'm just talking about clinical things. Just throw a bright light on the child's eyes. You will yourself see what the child does. That roughly indicates, yes, what is going on with the eye as such. That is what I do. Maybe our colleague can have more on that. Dr. Allen can.
Yeah, Dr. Allen.
Yeah, I mean, that's a whole talk in itself. I mean, a normal infant should be fixing and following by between 4 and 6 weeks of age. Only if they're not fixing and following by 6 weeks or beyond do you need to start really looking. And there are multiple different causes. Sometimes the vision can just be slow to mature, what we call delayed visual maturation. Children who have various problems, including brain injury, vision will be slower to develop. If they have any form of albinism, which is pretty common, the vision is slow. And something I saw quite a bit in Edinburgh was in children who were exposed to opioids during pregnancy. They definitely have delayed vision.
Okay, Dr. Allen, there is a question for you from Dr. Abdullah Abid. Good evening. I would like to request Dr. Allen if he has a short message for a GP, general practitioner. What are the danger signs in a child regarding brain tumor? And the GP should urgently refer the child to a specialist.
I suppose a change in behavior. If a parent reports that their child is not themselves, is different from normal, I think I always take that seriously, whether you're a GP or a pediatrician or a pediatric ophthalmologist, pediatric surgeon. Always listen to the parents, I think is a sort of a broad piece of advice that will always keep you right. If the child has developed a new if the child is generally unwell, has developed new neurological symptoms, ataxia, tinnitus, head tilt, squint, nystagmus, over a relatively short period of time, like a few weeks.
Thank you. There is a question from Dr. Batul. Is there any new treatment for astigmatism?
Short answer, no. In adults, there are various approaches, including laser for lower degrees of astigmatism, and special types of implant lenses are also certain contact lenses for higher degrees of astigmatism. But it's in children, basically, it's glasses. Dr. Singh might have something further to say, but
in children, definitely glasses only, nothing else.
Yeah.
Yeah.
So I have a question. Is there any terminology as ocular migraine or retinal migraine? And what that refers to?
Yeah. Well, Dr. Singh, do you want to go?
You please go ahead, then I'll talk maybe.
Yeah. Okay. Migraine is such a wide spectrum of conditions. There can definitely be visual symptoms of migraine, including transient vision loss. That's either at the retinal level, or sometimes people can get hemianopias, where they're missing half of their field of vision, and all sorts of sensory and motor changes. To answer your question, yes, it does exist.
And it's a pathological or just a transient and without any sequelae?
Usually transient. But you always have to take a very careful history. And if there's something that's different from, that's quite odd and not an uncommon presentation, I wouldn't hesitate to get a second opinion, say from a neurologist. I wouldn't necessarily go for an MRI scan first, but I would, get an opinion from a neurologist as well.
So, Diari, may I ask one question?
Yeah,
of course.
First of all, thank you very much. Both of you, excellent presentation. On behalf of all, I'd like to thank you. Dr. Allen mentioned you listen to the mother. Long back, I was reading one ophthalmology book. The moment you open the first page, it is written, listen to the mother. She is usually right.
Yeah.
I get 80% of diagnosis from mother. So nowadays, we see a lot of children with red eye discharge, some of them adeno. I mean, almost 50% of them. I would like to request the panel, how you approach, I mean, is it only adeno or something else? How do you approach as a pediatric ophthalmologist?
And Dr. Singh, do you want to?
Actually, I will, thank you. Actually, Dr. Sorab, you are very right. Plenty of cases like this, plenty of cases. Like daily, maybe I'm seeing at least 10. So but what we always talk about is adenoviral, and we always say adenoviral, and we know that how it affects and what it affects, and but what I see, a majority of this, it is not only viral, it is mixed. So that is why if I simply go with one drop, any antibiotic drop, which I know it will not help. If I look at the books and I will just go with the lubricants, I know it will not help. Because then I have to go with the mixed things. And I have to keep monitoring the child. This is very, very, very important, because what I'm talking is what I'm doing and what I'm practicing. I know the literature will say something different in different ways. But clinically, what results we get is quite different than what we see or what we read in the literature, because majority of them I feel are mixed.
So there is a question from WhatsApp from Dr. Manoj. Is enlarging preauricular lymph node can differentiate between viral and bacterial conjunctivitis?
That is one of the things. Yes, we do see large preauricular lymph node in adenoviral. We do say like that. Yes, this can be one of the things which can be seen in adenoviral.
It can happen in bacterial also.
It can, yes. That is both. That is why I told you mixed.
Okay. So Dr. Osama is asking, Osama Tayyib, please for the management of ophthalmia neonatorum.
Dr. Diagi, your internet.
So that you can answer it.
Yeah.
Dr. Allen, please.
Ophthalmia neonatorum.
Yes.
Well, so any sort of conjunctivitis in a neonate like under a month of age is a little bit more concerning than older. I think if the signs aren't terribly dramatic, if there's not terribly much lid swelling, just a swab to check for culture and sensitivity. A lot of them will turn out to be just bacterial. There'll be staphs and streps and Haemophilus, in which case it's just the same as any other conjunctivitis, and you can manage it with Pobridex or Fusidin. it gets more complicated if it turns out to be, say, chlamydia or even rarer, gonococcus. Gonococcus is very rare in my experience, but it's very, 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 very nasty. Get really horribly swollen eyelids, copious amounts of horrible discharge, and the child is very distressed. It's very painful, and it has the potential to scar the cornea. So it is an emergency that probably requires admission and systemic antibiotics and regular lavage of the eyes. But it would tend to be off the scale in terms of signs and symptoms.
So there is a question again on the same topic about prophylactic antibiotic drops.
For
the same, for the ophthalmia neonatology.
I think there is some countries do this, and they use, I think it's silver nitrate drops. The problem is, I mean, infections like the ones you worry about, like chlamydia and gonococcus, are systemic infections, so they require systemic treatment.
Silver nitrate eye drops should be very diluted.
I've no experience of using them. I've just heard of this. I think it's used a lot in low and middle income countries. I mean, if you were in a situation where you couldn't get hold of topical antibiotics, if you had 10% povidone iodine, you could dilute it 1 and 2 with saline, and you can safely instill that into the eye, and it would kill most bugs. We use it as that's the standard prep for eye surgery. That will kill most bugs if you don't have access to the normal antibiotics. But I've only heard of silver nitrate prophylaxis. I've no direct experience of it, and I'm not sure what exactly you would prevent, to be honest.
Thank you. Dr. Salija, she's asking about exact age at which laser surgery is suggested for a child with astigmatism.
Oh, not till probably 18 or 20 years of age, and laser will only correct a certain amount of astigmatism, probably not more than about 2 diopters of astigmatism. If it's higher, then laser won't do it. It might have to be some form of surgery, either intraocular contact lens or something quite exotic. Yeah.
So again, question for the panel: how accurate optokinetic nystagmatism testing for visual integrity in non-cooperative child and infants?
There's 2 possibles there. Well, one is if it's a very small baby and you're concerned about vision, then is it a non-seeing infant? You can use the OKN, but actually, what's almost better is a separate test called suppression of the vestibulo-ocular reflex. I literally sit in I ask the parents if I can hold their child and hold them in my arms facing me, and I sit in a chair and spin. And that introduces vestibular type nystagmus. And as soon as you stop moving, the child's eyes should stop moving if they have a vision input. And it's a very good test for a child who doesn't appear to be fixing and following, who's been referred at maybe 2 months of age but not seeing. It can give you reassurance that there is actually some vision there, and it's just a bit slow to develop. The other situation where you might use some sort of test like that would be an older child where you're concerned that it's a sort of non-medically explained vision loss. And that does occur in older children. But there's various other things we can do for that.
Thank
Dr.
you.
Gurdeep, any suggestions?
Actually, in OKN, usually we try to see the saccades. This is
Yeah.
what we try to usually notice. And if the child has a vision, you will see the saccades. This is that's basic of that. So yes, it can help us up to some extent. we can use that. But OCAN is rarely used now these days because of so many other things there. So, but that is the only importance OCAN has. And in some kind of a squints also, it used to be used. We say that it's an asymmetry of OCAN. So that used to be one finding in we call congenital infantile ESO. We used to do something like that, and we say this is one of the finding in that. So this is what usually we have in OKN like things.
Yeah, it's hard to find an OKN drum these days.
Yeah, correct.
If you're saying a question for you, maybe what is the right technique for lacrimal massage and congenital nasolacrimal duct obstruction? How frequently we need to do it?
For that to understand, you should understand the anatomy of the duct. Basically, the duct goes downward, backwards, and lateral. Okay, so the direction should also be like that. If it goes in that direction, and that too, the pressure has to be generated. And when you generate a pressure, because we do expect there is a membrane there, and we create an hydrostatic pressure. So that pressure, when it gets generated into that, that is getting transmitted down. And then that can open the membrane. That is what it is. So the direction of the duct tells or determines how the sac massage can be done. That is what it is.
Thank you. A question from Dr. Monica. Mother's own milk for eye discharge. What's your opinion?
And now I will see, Dr. Allen was talking about one scenario just now where he was telling the child with the gonococcus. Yeah. So with this conjunctivitis and the purulent discharge and all those things. I have one very bad experience with something like that. I saw a child, same like which I have shown in the picture with that kind of a discharge. And if you remember, I just told in the talk, if possible, just try to have a look in the cornea if possible. Otherwise, send it immediately. Now, what happened? This child had infection like this. Over that, there was a corneal injury there. I don't know whether it was during delivery or something. Now, this child got an infection from this. Over that, mother was pouring the milk. And believe me, in 6 hours, I have seen the cornea rattling down.
Dr. Kalpana, we are missing her. She has joined, but
We are missing.
She has asked some question in the box. I would like to request you just put those questions.
I think Dr. Gurdib also answered them, but it is good to know for all the audience which eye drops are not safe in G6PD deficiency.
G6PD as such, the quinolone groups of drugs, usually we don't use like Cipro or Moxie, most probably these drugs which are getting used, or we don't use these dorsolamides or acetazolamides or brinzolamide, that group of drugs. These are the most common things which we don't use these kind of drugs in that. Tobrex is the safest of all. That is why I mentioned about Tobrex. It can be used in G6PD. So if we have a family history of a child having G6PD, so we have to be a little bit careful. Although even sometimes we do have to use, then I don't just tell them to use it with the punctal occlusion here. I tell them to press it here and just use 1 drop and keep it pressed for some time. So even that, the concentration which will go into the systemic will be very less. Usually it should not cause unless it is a very frequently used drop. So that is what it is. These drugs usually we avoid in this. Plus sometimes we give this brufen and other things that, but not as a drop, but oral. And oral antibiotics has a long list as such.
And I think she also asked about a question. There was a patient you show the eyes with the blue sclera,
yes,
which was low hemoglobin, and so
yes, that was a very interesting child actually. So that child, as I told you, was seen with blue sclera, and Blue sclera can be considered normal even till 6 months of age. I told you the reason why, because the sclera is thin and you can see a reflex of the uval tract from down. So that is even sometimes considered as normal. But after 6 months, if something is there, yes, we need to rule out all those which we were talking. And hemoglobin, usually with the child which I showed you the picture,
Yeah.
that is not my picture, that is I have taken from somewhere, but the child which I had is less than 6. And there was a response with the hemoglobin. You have seen the in that child's picture also. So I also went and saw the literature that time. So it was a very interesting case for me from where I learned actually.
So Dr. Sophia sends her regards for both of you. She likes to ask, would you recommend myopia control for kids with progressive myopia? And if you do that, what's the criteria or cut off for ocular fitness?
Dr. Allen, will you answer?
Yeah, it's becoming increasingly common to try and treat myopia where there's demonstrated increase or progression in the myopia. Certainly in Al Jalila, we're using very dilute atropine, which is 0.01% once daily, which is very well tolerated. But kids are on it for quite a few years. I have also strongly encouraged the parents to try and get the kids to do less close work and spend time in natural light. There seems to be a strong advantage to using natural light. It helps to minimize the amount of increase in myopia. I mean, myopia is a talk in itself. I mean, it's a public health issue. It's become so pervasive in young people. But yeah, very dilute atropine definitely has a role. There's also special types of dual focus contact lenses and newer special glasses. Too much detail to go into, but there's a lot of developments in this. There's a lot of money being poured into it because well, there's commercial opportunities, I suppose.
Can I talk?
No, absolutely.
Yes. Regarding these, Dr. Allen has already mentioned regarding the atropine diluted concentration drops. Yes, the world over in now they are using everywhere once in the night, and they have shown good results also. Unfortunately, I have not found them so good with my own practice, which I have seen here. But one case I will always share is like I had one child which was on this atropine, and we do say it is a very diluted medicine. But this child was very mischievous. So what he did is he had an exam next day, and on the day before night, what he did is he didn't put it once. He put it like 4 or 5 times. And then this child's mother is calling me and telling me my child cannot read. Then I told, why he cannot read? What is his problem? No, he telling I cannot read. What drops you have given? So that became even headache for me that day. So now whenever I give them, I always ask them about this. Please do not use it more than once and only once, and you only put. I specifically tell mother you only put, because these children you cannot believe. Second thing is regarding the glasses which Dr. Allen is talking. Yes, there are some glasses which are getting used for these kind of things, and one is I think I don't exactly know, maybe myoplex or something like that. But I have gone through their literature very well, and what I have seen in those lenses is like the failure rate is almost 30 to 35%, and you are spending a huge amount on that.
Yeah.
So if you have a failure rate of 30 to 35%, and when you are spending like 1,500 or 2,000 on some glass like this, and in year you will have to change it like 3 times the glasses, then you can see where it will go. And I had a person from same company also who they are still going to launch something new, and I was talking to him. So I was telling him, your studies, whichever you are showing, there are 2 studies. Your study is only 1 year. And you are talking big things. What kind of a study and how you are going to prove that? So he had no answer, but he was just smiling and telling me something like that. So what I found is, yes, the atropine can be used. The glasses, you can combine them also, but there can be additional expense which we need to tell to the parents. And despite that, also even the contact lenses which have been talking about, the results are not so favorable. Maybe it doesn't make much difference for me if my child has -6 instead of -7. What difference it will make it to me? Because I will be spending so much for so much time, each and everything. And this is what I feel. This is my practical experience which I'm talking.
Thank you. There is interesting question from Ajay. If a mother is hypertensive during her pregnancy period, it can affect an upcoming baby, eye or ear. Like a mother diabetic and cause the diabetic.
I think that's more a question for an obstetrician. I suppose it's not good for the placenta.
Yeah,
imagine.
so generally might affect everything in the baby, rather than only eye.
Yeah. I would have thought so.
May I ask one question from panel with your permission?
Please.
This is always a dilemma. Dr. Manoj also has asked, what is the latest about the examination of eye by ophthalmologists? I mean, when an ophthalmologist should to examine the child, when pediatrician should refer. Well, I mentioned about the American Optometry Association, but what is the latest?
That is what I talked in universal eye examination of newborn. It should be at birth. This is what it is. The trend is going on now like this. This is the latest trend which is going on. Unfortunately, we are not following it here. Even I have tried with my hospital also. I'm not able to get a success in that because money gets involved. Nobody wants to pay. Insurance doesn't want to pay. Parent doesn't want to pay. But if they will go to ENT person, they will pay. But if they have to see the eye person, they will not pay. And later on, they will only come crying that my child has this, my child has that.
No, but routine examination of children. No, routinely, how often, at what age children should come to either optometrist or ophthalmologist for eye checkup? I mean, during the school years or preschool, which years you recommend usually?
At first is at birth, if he is not premature. If he is premature, then it starts early than that. The second one is at 4 to 6 months of age, because the fixation develops by that time. When we say fixation develops, we meant it is central, steady and maintained. That kind of a fixation usually is 4 to 6 months, which we talk. Some little early, some little late. So by that time, 4 to 6 months is the ideal time to look at what is going on. If everything fine, then preschool. Maybe Dr. Allen, a little more on that.
Yeah, that's very reasonable. Yeah.
What I mentioned, American Academy of Pediatric and Nelson say all children should be examined at the age of 3 years by ophthalmologists, 3 to 6 years every year, 6 years and onward every 2 years. Normal. All children, they should undergo this examination.
I'm not sure the resources exist to do that.
This is mentioned in Nelson, and I mentioned about the American Optometric Association, guidelines also. Because many mothers, many pediatricians ask this question, when my child ought to be examined?
Yeah, I mean, if I was to pick a time, I would say about 2.5 to 3 years of age. If you could only do it once after infancy.
Dr. Allen, Dr. San, I think we have to wrap up because I know you have clinic and OTs tomorrow. So your final word on eye discharge, both of you, please, because there are a couple of questions on eye discharge. Just in 30 seconds, anything about eye discharge.
Small infants under a year of age often the commonest cause of eye discharge is a blocked tear duct. And I would suggest not doing repeated swabs. Don't do repeated swabs because it'll just grow some bug that causes everybody a lot of anxiety. And I would just encourage lacrimal massage instead. I don't know if Dr. Gurdeep feels any different, but
Definitely, that is true. Only lacrimal massage, definitely in a child with the discharge at birth, provided lids are normal, there's no swelling lids, discharge only their eye is white.
Yep.
Back massage.
Thank you very much. Thank you, both of you.
Thank you.
Amazing. Thank you. It was very
At the end, I want to thank Dr. Gurdeep, Dr. Allen, Dr. Diari, Dr. Kalpana. We understand. Tawfiq. One question I want to ask again, this I read it in a Pediatric Ophthalmology. Shakespeare said, "Oh, mistress, behold upon my eyes the window of my heart." What is relation between eye and heart? So much Shakespeare expresses this. Maybe Dr. Allen can answer this question.
It probably relates to this, the sympathetic nervous system.
Nice.
Thank you very much. I would like to thank all viewers. This time, this time about 600 viewers from all over the world are following us. I would like to thank all of them. Once again, I would like to thank our speakers, Tawfiq, Fadi, everybody. Thank you very much. Once again, I would like to say our annual conference will be on April 29th and 30th at Conrad Hotel. It is free registration. We will give you the link and we expect everybody to join us. Thank you very much and good night.
Thank you very much.
Thank you.
Thank you, Dr. Allen.
Good
Thank you.
night.
Thank you.
Thank you. Thanks for inviting me.
Thank you. Thank you. Bye.